Hi, this is Dr. Tom Rogers coming to you with a weekly podcast of what I call the Common Sense MD. Today, it's an honor and a pleasure to have a fellow physician and friend, Dr. Herb Ladley, who's a cardiologist here for many years. And I wanted to get him on today because our number one killer is heart disease by far. So in my opinion, our cardiologists are the number one specialty that there is. I mean, they're the ones that are really the lifeblood of the hospital. If you ever hung around a hospital, the cardiologists basically run the hospital. So, and it's very important, especially with all the advances in cardiovascular medicine, what they're able to do. But I want to talk to you today, Herb, about what you can do to prevent heart disease. You know, there's Proverbs 2 something says, guard your heart.
Always.
We're talking about that before, so I want to really tell people what they should be doing as far as screenings, keeping themselves in shape. We know you shouldn't smoke, but what about some of the other things? First of all, I will say that you were the second or third cardiologist in this town in Kingsport. It was Dr. Harry Turner first. You joined shortly afterwards,
A few years after that, Larry Cox, and then another cardiologist was here briefly but left, and then Harry and Larry and I were here for a few years before we started recruiting furiously.
And you did an amazing job of it. CVA is a world-renowned cardiovascular association. I mean, it's amazing to me the quality of cardiac care we have in this town and the whole region now. I mean, I can't tell you how impressed. It's just incredible that for a place this size, what we have. So congratulations in helping build that dynasty. But anyway, so what drew you into cardiology in the first place?
Yeah, that's a good question. Oddly or interestingly, I knew I was going to be a cardiologist like the second week that I was in medical school. Just didn't dawn on me to do anything else. So I enjoyed it, the physiology and its marriage with the anatomy and how important and how common the problems were. So I kind of was on the trajectory of a cardiologist very, very early.
Interesting.
Yep.
Could you have imagined what has happened since with, I mean, when you started, they didn't have cardiac catheterization probably.
It was pretty new then, yeah. When I started in medical school, when I came here to Kingsport, we did have one cath lab. It was some technology that's long gone, what's called a fixed eye, where they take a picture just straight through, and you have to move the patient. Now we can move the imaging, but then we had to move the patient in order to get different views. Yeah, that was the earliest types of cath labs.
So when was the first invasive catheterization done in this town?
It was done, I believe, at Holston Valley. I think it might have been Harry, actually, to do the first catheterization. There had just been a couple of angioplasties when I came to town. Larry Cox did some, and I think one other person was doing, but not very many. So I think 4 or 5 when I first came.
In what other ways have you seen cardiovascular services change as far as advancements? You know, we have open heart surgeon. We have a guy that lives right down the street from me, Dr. David Sewell, that came in. He was our first cardiovascular surgeon, I believe.
Great surgeon, fantastic. Yeah, I think one of the main things has been the ability to revascularize the heart without surgery. So the development of coronary angioplasty and stenting as a discipline that's grown and grown and grown. And here at Holston Valley, we've been able to do that as well in parallel and in a team cooperation with cardiac surgery over the years as well. So, and the other part that was new when I first came but isn't any longer is the whole electrical arena of heart rhythm problems, device management, and the impact of those two when the heart becomes diseased and damaged, that many times it needs some sort of electrical intervention or a management of electrical instability that goes along with the structural heart problems.
That is an incredible advancement. My wife, Jenny, has had 2 ablations for SVT herself, and the first one didn't work 30 years ago. The second one worked like a charm. So that is a great added thing that we can do now. So, and we're talking about people that already have a heart problem. Let's talk a little bit about prevention, which to me is very important. How do you go about counseling people? You know, I do this thing in my office called the Cleveland Heart Panel, which gives me, you know, a vast array of numbers to look at, from inflammatory markers to how thick your blood is to the particle size of your LDL, how oxidized it is, along with your insulin resistance. What would you advise somebody that was, you know, say 40 years old, and they were wanting to take care of their heart and prevent having a heart attack, because it is a major killer of everybody?
Absolutely. So what you're doing in terms of the chemical panel, the metabolic panel of an individual patient is crucial, and some simple screening. You and I have talked about calcium artery scoring, which is an excellent screening tool for patients that do not yet have symptomatic coronary disease, but may be at risk of it in terms of their risk factor profile. And I personally have had a moving understanding of coronary artery calcium scoring. I think a calcium score of 0, for one thing, I had learned, and you've helped, that there is a such thing as a false negative, that a 0 may not be, depending on the imaging, the sophistication of the imaging. A calcium score of 0 there is a false negativity rate, so not to be too comforted if there are other findings that you come up with in the metabolic panels. And then the other recognition is how late in the process of coronary disease an abnormal calcium score is. By the time they've had a plaque that's ruptured and they've had some calcium buildup in the artery, they're down the road. We're down the road in terms of heart disease, and some of the things you're talking about, trying to identify the earlier indicators and deal with them, are even more important than some of the screening tests that we do that pick up the disease later.
You know, I guess we all are developing atherosclerosis as we age. I know when, you know, they've taken these 18-year-olds that have been in car wrecks or war casualties, and they look at their coronary arteries, they already have some plaquing in them. Is that right?
That's correct. That it's a disease that begins early in life. And even the calcium scores for my own personal health, I realize that data has a 10-year window, that it's looked down the road in the prognostic utility for 10 years. But as you point out, this disease is a disease of many decades, and to try to avert the consequences 20, 30, 40 years later, you have to get up on the leading indicators like you do with your metabolic panels.
So you're saying the CT calcium scoring is helpful, but it's just another tool. You need to look at everything else. You know, in functional integrative medicine, we think that inflammation and insulin resistance is the main driver a lot of this metabolic syndrome that people have.
It is, and as well as coronary disease, which is a later lagging indicator of the metabolic syndrome and inflammatory state that people have had.
You know, when I first started performance medicine 17 years ago, really what got me to do it is because I realized I was treating all these obese people with a lot of medications, and they weren't changing their lifestyle at all. I mean, they were still obese, and their numbers may have looked better because they were on a bunch of medicines for it, but basically they didn't look or feel any different than they did before.
Exactly, and I think the more you wrestle with the downstream or later manifestations of heart disease, the more interested we have to become in the upstream prevention. And so the panels, the metabolic management, the role of exercise and strength training in every one of the metabolic problems that become coronary artery disease, personally have made that as much of an emphasis with my patients as the technical work that we can do as well.
And you're an unusual doctor because you actually talk to people about their lifestyle. And what I've found is that if you can get a person, no matter what family history they do have, that can be a part of it. But I think it's vastly more important how they're living their lives. I mean, how they're exercising, what their weight is,
Exactly.
what their visceral fat is, what their blood pressure is, what their insulin numbers look like.
Yeah, I agree, and I think as a profession, we cardiologists can be criticized for not focusing enough on that. That we generally, with one foot out the door, encourage the patient to get some exercise and lose some weight, without specifically saying do this. And so I personally spend a lot more time with patients that are on a trajectory, either have had coronary events or on that trajectory, to say, well, let's talk about doing exactly this in terms of working on their own physical conditioning. And
I've followed cardiologists around the hospital at different times during my career, and it seems like when you're a cardiologist in the hospital, it's almost like your pants are on fire. You're going from one disaster to another.
Yeah, and it's interesting. That is one of the lessons for Holston Valley is never build a hospital on a hill. much less string 5 buildings across the hill.
Well,
but you can get a lot of steps.
You get
in.
your exercise, I guess.
I get my steps. Yeah.
But because that's I think that's a very stressful job. I'll give you a lot of kudos because I'm not sure I could do it. It seems like you have a lot of stuff going on. Then you get back in the office, you get called back to the hospital. You've got somebody crashing. It's a little better now than it was probably when we started our careers because you have some more coverage, right?
Yeah, we have a great team, not just the physicians, but the staff in the hospital, the nurses and the technologists in the labs and operating rooms are fantastic, and they take care of us, and we owe so much to them. So it's a team sport for sure.
It really is. I've often said, if it weren't for nurses, they really are the foundation of the care in the hospital.
Absolutely.
No doubt about it. So let's switch gears just a little bit. So advice on preventing heart disease, besides screening, besides losing weight, staying in shape, not smoking, making sure your blood pressure is great. What about, something I've been doing? I'm 69 years old. I've been taking an 81 milligram aspirin since I was 40. And I know there's controversy about it. Every once in a while you hear, well, it doesn't help. It could be dangerous as you get older. I'm still going to do it because I think it's, when you weigh the benefits versus the risk, at least for me at my age, I'm going to still keep doing it. Yeah. What are your thoughts about it?
That's a good question. I think you can get in a fight in any coffee shop full of cardiologists about aspirin for primary prevention. I happen to agree with you. Because I think again, the disease is such a long-term disease, decades and decades and decades, that the things you can, when you think you're fine and protected, in fact, you can begin to invest in preventing the disease and the event rate down the road. And that's one of the things we've learned about heart disease is it's not linear. It's a disease of events. Things are fine, then there's an event. Things are fine, then there's an event. Aspirin is probably one of the agents that helps to quiet the events. Statins, as we've talked about, are probably another. They're not perfect. Hopefully they will be better, and they may be better right now. They're just not in the marketplace the way statins are.
And they work because of they're a good anti-inflammatory. It's not necessarily because it lowers your cholesterol so much. But
right. They're sort of chill pills for the plaque that does develop over a period of decades and decades. So.
Yeah. I'm certainly not against them. They're like aspirin. They're controversial. They're not without side effects. But I'm certainly, I have people that come into my office. I'll never take a statin. Well, certain people, I'll tell you, you're one that needs to take a statin.
But on the lifetime prevention that you mentioned, I think to have the respect that it is a disease of a lifetime, and if someone says, well, I'm just doing fine at 30 or 40, you probably still have the opportunity to invest in preventing the disease when you're 60 or 70.
It's a progressive disease, is what you're saying.
It's a progressive disease. Starts early, goes on for decades, and by the time we recognize it with some of our tools, it's been in play for a while.
Another argument I have with my patients or pointer that I tell them.
You don't argue, do you?
I don't argue with them, no. I believe a patient should work together with a physician like you. I try to listen to them and work with them. If they don't want to take certain things, I say, this is your body. This is your decision. It's up to you. I'll give you my advice. But in any event, when I tell people that aspirin also lowers your risk of cancer, there's a ton of evidence that it does, especially GI cancers like colorectal cancer, maybe up to 40%. And then they'll go, okay, I'm going to take the aspirin every day. But certainly, if you're really old and falling down all the time, if you have a stomach that may be prone to a GI bleed, it could be dangerous.
Right.
But so we have aspirin, we have possible use of statins, blood pressure medicines. And so now we have these medicines called GLP-1s that, like Ozempic and Mounjaro, that have been tremendous tools for weight loss. I mean, I've used them thousands of times because people come to me to lose weight. We've realized that obesity is a metabolic problem of insulin resistance. Doesn't have a lot to do with laziness. You may eat the wrong foods, but there's an insulin resistance problem with this. So there's also a lot of evidence that these things will lower your risk of heart disease and heart failure. Aren't you cardiologists kind of excited about this as well?
Yeah, there's a couple of classes of drugs right now that are having studies come out that are really revolutionary studies in terms of the impact on cardiovascular mortality. And those drugs in particular and the relationship of weight loss. There's one caveat that's probably worth understanding, and that is some of the weight loss includes lean muscle mass.
Exactly right.
The way that glucose and most of the body fuels are metabolized starts in the muscle. And so losing lean muscle mass with your body weight loss, I do counsel my patients to integrate some preservation of that with so losing enough weight to begin some resistance training needs to be the goal.
Exactly right.
Not just the weight itself, but the ability to then get back to some primary treatment, which is some resistance and strength training. That is
such a great point, because as a matter of fact, that's why when I started reading those reports about Ozempic causing lean body muscle loss as well as fat, I bought those in-body machines that actually measure it. So when I get a patient, I want to measure it before, then I'm going to measure it 3 months later after they've been on Ozempic to see if they're losing muscle. In the meantime, they're probably not eating enough protein. They're not doing enough resistance training. So, all the medicines, all the advances we have with cardiac catheterization, stents, all this stuff, you still need to follow the basic tenets of daily exercise, including weight training. You need to get a good night's sleep. There's a lot of sleep apnea that I think is undiscovered out there that can cause heart disease.
Absolutely.
Do you recommend that a lot of people get sleep studies?
I do. We have sleep studies for the vast majority of our patients with coronary disease and arrhythmias. Like atrial fibrillation, very common arrhythmia. Over the decades, we have come all around full circle to recognize that the basics of good health, sleep, blood pressure management, weight management, resistance training is probably as good for atrial fibrillation as many, if not most, of the medicines and many of the procedures that we have.
So that is such a good point with AFib association with sleep apnea. I see that a lot. There's also a new controversy that, maybe fish oil causes more AFib than somebody that doesn't take it. So again, you got to weigh the risk versus the benefits. But so good exercise, the right kind of nutrition, avoiding processed foods, and the thing about a low-fat diet's kind of been disproven a little bit. I know a lot of the cardiologists talk about you have to get on a low-fat diet, but really it's the kind of fat you're eating, isn't it?
It is the kind of fat you're eating, and it's a lot about ultimately the total calorie count and what you're fueling. You mentioned protein. I think people that are trying to add some resistance training in their day-to-day life, which they should, probably need to look at their protein and make sure they're taking enough protein to maintain, if not add some muscle strength.
I agree.
Because the other thing that does that we talk about a lot is try to have the stability ability to not fall. And in the resistance training is the opportunity to develop the stability ability to not fall.
I like the way you put that. I'm always telling people when they go home from office, if they're getting a little age, like we're getting a little bit, I want you to go sit on the floor and see if you can get out of the floor without using your arms. And that's a very important measurement. So I think balance is so important with people. And you're right. It starts with resistance training. It's not just standing on one leg. You have to build muscle because you're losing it.
Yeah, absolutely.
And get on some protein like Perfect Aminos. Take your vitamins. Be proactive. So there's a lot of common sense things you can do as well. So just know that we've got great cardiologists in this region like Dr. Herb Ladley and CVA. It's just been an incredible blessing to this whole community that you had a part in starting that. And Jerry Blackwell and all those guys that are just incredibly smart and caring. You know, I really want to thank you publicly for what you all do. It's just an amazing comfort for me to be able to call one of you guys and talk a case over with you.
Sure, and it's a blessing to have the team that we have. It's been great, still is. Still at it.
You are exactly right. You're at the beginning of it, so I want to thank you, and thank you for coming on today.
Thank you.
We'll do this again, so stay tuned. This is Dr. Tom Rogers at the Common Sense MD. We'll see you next week.
Thank you.